Good evening, everyone. The topic for today is infectious diseases and tropical medicine. And the speaker that we have here is Dr. Anand Joshi. He is a consultant, intensivist, and physician at Gamman Hospital, Hyderabad. So, you can take over. Thank you.
Welcome all back to this fourth session in the series of the lectures on the infectious diseases and the tropical um, diseases. Uh, we were discussing about the tuberculosis, and as you know, the tuberculosis has a wide variety of applications. So we last time stopped at the treatment and the regime part. Just a quick cap on the few of us two slides which we spoke about the treatment. We are all aware of the first line treatment: isoniazid, rifampicin, pyrazinamide, and ethambutol, and we also know the standard regime of 2 months and 6 to 12 months, depending upon the disease severity. We also went through about the second and third third line of medications, especially the fluoroquinolones, injectables, aminoglycosides, polypeptides, ethionamide and prothionamide, and cyclosporine pass. We also went through few of the antibiotics which you might come across when the tuberculosis is detected, and they would be giving the sensitivity to. Those are the linezolid, amoxicillin, carbapenem, clarithromycin, and you would be a bit surprised why they are giving this, because at some point of time they were thought to be useful in tuberculosis, but they are no longer used in treatment, or they should not even be considered. There are few bedaquiline and delenamide new class of antibiotics which we will be going through. So why do we need a regime for treatment? So whenever you have a bug which requires more than one drug to control or kill, you need to have a kind of regime in place which will tell us what exact dose, what exact combination, and what exact duration of the time we should be using to achieve cure. Now, we know that the most common for the tuberculosis is a short course tuberculosis, in which we have 4 drugs for the intensive phase. Now, the importance of this 4-drug intensive phase, which is usually for the 2 months duration, is we try to attain as much bactericidal state as much as possible, and the patient has to become asymptomatic and non-infective. So that's the importance of the intensive phase, where you go all out and try to stop and kill all the bacilli. Then you continue this drug. Now you know that this tuberculosis bacilli is a very tricky bacilli. It stays inside intracellularly. It stays inside the body in a dormant phase and tend to come now and then. And it's a slow growing bacteria. So to eliminate those couple of bacteria which are stayed behind, and to sterilize, we continue with the continuation phase of the 2-drug, which would again be bactericidal drug, that is INH and rifampicin, for extended duration of time. And now for that, if you see if there is a culture positive or smear positive, you continue for 4 months. New culture negative case for 4 months, and then we have those things variable when it comes to pregnancy, which we'll be talking a bit detail later. Relapsing and a failure treatment again has a bit of a different, slightly different regime in terms of addition of streptomycin. Then you have a failures, and then you have a multi-drug resistant and XDR TBs. Now, the standard short course tuberculosis regime of 2 months and 4 months should, and if the bacteria, and assuming that this bacilli are sensitive to this drug, 90% of the patient gets cured in these people. 10% get left out with various reasons that we'll cover later. So if you're using this, if you get across somebody who's got a tuberculosis and who's fitting into a regular straightforward criteria, remember that these 2 months and 4 months are enough. In 2 months, you should get your patient asymptomatic and non-infective, and the rest of the 2 months would sterilize the patient. Now, that regime, we use it for the daily intake, but there, because of the various reason, the government also came up with, or the various authorities came up with, thrice a week regime. Now, though this regime is applicable for most of the general population, however, there need to be selection in this. It is offered to a non-HIV patients, and these people who are on thrice weekly regime, irrespective of that, are likely to develop resistance and treatment failure. So be careful when you are using this thrice a week regime. Now, what would be the reason and most common factor for developing the resistance or the treatment failure they found out was a lack of adherence. So just that the patient doesn't take the tablets, or it's the tablet doesn't reach to the bacilli. And what there are few factors, that is patient factors and the provider factor. In the patient factor, it's a lack of belief that this illness is serious, because tuberculosis is such a slow growing. It's like a termite, which is eventually going to eat you up and kill you. Uh, Also, this 4 drug regime is like, if you ask somebody to take 5 drugs daily and make a scene out of it, then the effect, even if you get an effect, you get 1 to 2 months. So at some point, this patient who are used to, say, feel better, and they would expect that it should be making magic in 2 or 3 days, they start thinking that whether this treatment is beneficial or not, and then they stop taking the medications because they say it's not working. Certain concomitant medical conditions like alcohol or malnutrition or drugs becomes a challenging factor. They forget the drugs, they don't want to have money, the poverty is there, there is a joblessness, homelessness, there is a lack of social support, there is social stigma. Oh, somebody's got TB. It's a big deal in endemic countries or in the Indian subcontinent. There is some role of the provider also. If there is no adequate funding, then there will be no one to provide. If there is a direct observed therapy, then and the person is not given his salary or paid his wages, then he will not go, and that the drug won't reach to the patient, and ultimately the resistance develop or the patient succumbs. Uh, the direct supervision therapy was one of the ways where the authorities and the various government found out that we can overcome the lack of adherence with that. And this seems to have improved compliance and decreased the failure, relapse, and drug resistance. So this is one of the most successful therapy, or the DOTS therapy they call it, direct observed therapy, in which the patient is actually asked to swallow and drink a glass of water in the front of the burqa. The third thing is, in this regime, important thing has come up is the availability of the fixed dose combination. So if the previously when they started, they had these 4 drugs to be given as per the weight, and then looking at so many tablets, of people would really become non-compliant. So the pharmaceutical guys came up with this a big tablet with a fixed dose combination, and that has surely decreased the dose related issues.